Thank you, Sanjay. That's a very extensive NASH study lecture, and it just shows that audience stuck to it the whole time, the lecture. So that shows that how much informative and interesting it was. So with that, we'll take questions. I'll start with the first question. The nutrition is always the most important thing and the difficult to study. The branch and amino acid story. The data with this theoretically definitely is helpful, but the data is they're very conflicting whether it improves liver-related outcome. What's your take on that?
Well, we know that as on my initial slide, I do mention about how branch and amino acid, affects the AKT PKB pathway and FOXO and all those, and clearly it does so that the branch and amino acid promotes muscle protein metabolism and improve muscle protein synthesis, and whether there are any large-scale studies. Yes, there are no big studies, and I think this is also important. Despite we know all this pathophysiological mechanism, I believe there are not large-scale studies in this area in cirrhotic individuals particularly, and I think it's a good time to start working on this and on a long-term and with a long-term follow-up, at least 1 year or 2 year follow-up, and see this patient how branch and amino acids potentially can affect the outcome of cirrhotic individuals. But I do feel there is a theoretical basis for it, and would be nice if we could collaborate on this kind of studies and see in these patients. But certainly there is a theoretical basis.
So where do you ask the patients to go to get branch and amino acids?
Well, branch and amino acids are actually available over the counter. These are dietary supplements. There is no restriction to use branch and amino acids. If you simply can order on Amazon as well. I mean, I have spoken to many of my patients, especially for hepatic encephalopathy prevention as well. Even these are refractory to other managements, and sometimes I've added branch and amino acids as a therapy. And these are available pretty freely. You don't need a prescription for this.
Sir, this is Rinki. Hello.
Yes, Dr. Das.
Yeah, thank you, sir, thank you for your exhaustive talk. Fantastically, you have touched all the corners. And my question is, sir, how do you decide about futility of liver transplant in a given patient? And how frequently you find this nutritional interventions is effective in avoiding a futile transplant in clinical practice?
I think that's a great question. And look, we all know very clearly, we know how sarcopenia and frailty affects wet lease mortality, and we outlined a lot in my study as well. And with regards to futility question, I will share our personal experiences at our center. And many of these patients who come in with a low MELD and they're suffering through this sarcopenia and frailty, and especially bed bound, I would say, we've been able to save these patients by intervening their nutrition. What we do have is we have a nutritionist and a physical therapist who routinely be around with us, and we assess their nutrition and their need, the calorie intake, 24-hour calorie intake. And once we identify those calorie intake, there is reduced calorie intake orally, we put an NG tube in these patients in the hospital. So we do enteral nutrition, and then of course the physical therapies are graded severe. As I outlined in my toolbox, we do a graded severity. So we do that, and then we assess weekly for any improvement in the liver frailty index. If these patients are showing improvement, and then we proceed with their transplantation. Of course, if there is no improvement, they're deteriorating and they're now having bad sores and all that, it's very hard to get this patient through the transplantation, and we have to draw a line. But I will tell you, in some patients, even severe frailty, even I had a patient who had bed sores, and we had and with the vacuum wound bag placed on the back, we were able to successfully transplant. This individual is now a patient who is a fashion designer actually, and now been very successful in his life afterwards. So we have turned around a lot of these patients, but I agree there is a line you have to draw at some point. And if the patients are not responding to a rigorous intervention, we have to draw a line at some point and have a realistic discussion with the patient at that point. And this is, I think, individualized. I don't think any specific guidelines are there, but usually a 1 or 2 weeks of intervention in the hospital with the intensive hospital setting, we should follow and try to assess the liver frailty index improvement during that time. And many times you cannot assess the full liver frailty index, and the hand grip strength alone is a good marker for that improvement in those individuals.
In the same context, I think, Dr. There is another question about how do you assess the frailty in ICU setting?
Yes, actually, that's a great question. And we actually do not, although you measure the liver frailty index, but it does clearly show that somebody is in ICU and is bedbound, you're pretty much, the other markers are 10, like, they're the highest. And so you put them in their frail. I mean, you don't really need to measure their liver frailty index to say that they're frail, they're already frail. But of course, if somebody who is not, like, although because of the medical issue, they were not able to assess the balance and other things. So we simply do the hand grip strength, and it's a powerful tool, as I mentioned to you in the various studies. Just simple hand grip strength is a good tool to measure their liver frailty, their muscle strength also.
Yeah. Go ahead, Benedict, go ahead.
Sorry, I couldn't get my mute button done at that time. So it's a great and comprehensive talk. Thank you very much for that. I had I think when it comes to frailty, like you said, there are probably liver causes and non-liver causes, and so before using it along with MELD, there might be a role for maybe 3 months or something to try and reverse it. And so if it is due to a liver cause, I think definitely transplant is the solution. But if it is a non-liver cause, which could be decreased caloric intake or those kind of things, I think there must be some way of giving a 12-week of intensive physical therapy and nutrition, and if they improve, then their weightless mortality will decrease, and they may not need urgent transplant. But almost like I think we transplant alcoholics who don't improve after 8 or 12 weeks or something of abstinence, and if they worsen, that may be the time to give them extra MELD score. That's one point. And the other thing is whether there are studies where they have used aromatase inhibitors, because we know that testosterone gets converted to estrogen, with or without testosterone, whether use of aromatase inhibitors by itself has some benefit. And the third thing is in patients with diabetes, especially when they have advancing cirrhosis, maybe metformin may not be the best drug because it decreases gluconeogenesis, and I don't know if that worsens muscle breakdown.
Benedict, I think you made some very good points, and as we learn more and more, and the combinations of liver frailty index, the MELD score, we clearly have shown that many studies have shown that there is a clear correlation. Now, I will tell you one thing: like patients with this, I agree with you that there may be a need for a wait time, but how do we assess who needs to wait 3 months and who does not need to wait for 3 months? Now, somebody with acute alcoholic hepatitis, who's likely a robust individual, the MELD score actually kind of trumps the liver frailty index. Probably it's not going to add a lot because they're coming with a very high MELD score and likely either need a transplant or they improve with their medical management. Okay. So whether the LFI will add anything further, probably not. Going to already, you have a cap MELD score of 40, so it's not going to add one. But the other individual,
it might be like MELD sodium. Sodium effect is also at lower MELD scores. Same way, frailty should give you higher scores at a lower MELD. As MELD gets About 30, 35, yeah.
That is what I'm saying. So because so the other group of individuals who are like chronic alcoholic liver disease decompensating, these are individuals already frail, so if their MELD score is low and they're frail, I think that will help them to get like the MELD sodium which you mentioned. So they will add potentially to get them there to get a transplant. I think we see that all the time. So all the time these are low MELD score, and we clearly saw in one study as well a low MELD score less than 15 with the liver frailty and sarcopenia. They are more likely to die otherwise on the wait list. So I think something needs to be done.
Maybe it's a good idea to identify which patient with frailty will not improve. I mean, there must be some liver-related frailty will probably not improve with the liver transplant. And the question is whether you can identify those people with some scoring, which is independent of, non-liver. So, some additional thing. I think that is where ascites and encephalopathy, if you have both of them or one of them, they probably are worse off in terms of they probably won't improve as well as a person without ascites or encephalopathy. So I think the more you have, the more, the less likely they will improve with any intervention other than transplant.
Totally agree with you. The other thing, second question, I don't know that I know the answer to that, the aromatase inhibitors. Potentially, I haven't read much literature around aromatase inhibitor and Frailty and sarcopenia. The third question I think you mentioned about is, what was the third question? Remind me. The
metformin.
Metformin, yes.
Metformin positively or negatively impacts.
Yes. Well, again, metformin and any cirrhotic individuals, there is an increased risk of the metabolic acidosis, and usually with the child's BC, we try to avoid, and are likely, and also as you rightly mentioned, can promote weight loss. And probably not the best in cirrhotics with frailty already established. But whether this will be of any benefit in NASH patients with obesity, I think something needs to be determined. But we don't know much in terms of whether to avoid or not to avoid. But certainly I would avoid in patients with frail individuals due to increased risk of other complications as well as muscle wasting.
Yeah, and the other main thing is that with obesity as cause of liver disease, and we are using more and more GLP-1 agonists, I think when they already have cirrhosis, I think when people lose weight, they also lose muscle, and so I think there has to be some exercise and resistance exercise, etc., combined, because weight loss may not achieve benefits unless it is combined with improved sarcopenia and improved frailty.
Yeah, we had published a study actually in liver transplantation a few years ago, and what we have shown that in obese individuals at different levels of obesity, as well as those who are have a BMI less than 19, the NASH patients with the lean NASH, basically, that means the patients who are diagnosed NASH or have all the metabolic syndrome complications. It's a EUS database, so we define that basically NASH as somebody with all the comorbidities as NASH and their BMI low, they're at highest risk of mortality. So that means what? So if you promote weight loss in these individuals and get to this point of malnutrition, then they are going to have a worse outcome. I will tell you, when the BMI goes up in NASH patients, with the increased BMIs, they have a better survival after transplantation. Probably they have a preserved muscle mass. It has not been well shown, but what we assume based on this study, that higher especially this is actually comparing with non-NASH individuals. So NASH, when you compare with the NASH patient with higher BMI has better long-term survival. So probably by promoting weight loss, we may do harm in these patients unless we combine with improving their strength and exercise. So I think this needs to be studied. I don't think we have a real data, like prospectively studied data on it, but I do believe that's what it is.
Thanks.
Yeah, that's a very important area. We'll come to that. Before that, there was some question from Dr. Colombo. Are you still there?
I see, is testosterone administration is safe to frail patients with sarcopenia affected by HCC on top of cirrhosis? Probably not a good idea. The testosterone actually there is an increased risk of HCC, and absolutely will not be used in cirrhotic individuals with HCC. Will not be used.
So, Dr. Colombo, do you want to ask the question yourself? Introduce yourself. I see you're still here.
Okay, thank you for your answer. I predicted, in fact, we do not use testosterone in these in frail patients with cirrhosis and liver cell cancer, because we are perfectly aware of the additional risk you are posing to those people of having, stimulating the growth of liver cancer. So thank you so much for your confirmations.
Yeah,
So,
Dr. Colombo, could you
Yeah,
could you introduce yourself? Where are you from? We'll be happy.
Okay.
for the
I'm a
audience.
hepatologist in Milano. I spent my life working on viral hepatitis and liver cancer. So that's why I put the question.
Thank you very much for attending today.
No,
You're very welcome indeed.
yeah, thanks for attending. I appreciate it. No, Sanjay, then if you don't use testosterone, going back to Benedict's question, so what do you recommend? We talked about life effects, all these studies going on, but what do you think is the future?
We don't have a pharmacotherapy as of yet. We do not have it. We all were focusing. That's what my final summary slides have clearly mentioned. Physical therapy, nutrition are the key, but that is also not been well done. These individuals, you need to have a very stepped approach while even inpatient and getting this patient while they're in the outpatient follow-up, and should be seen by a behavioral specialist. We need to address their disease-specific etiologies, and the exercise prescription should be by the fit that we talked about, and all those things. But other than that, that is not much around it, and this is a very fertile area of research, especially with pharmacotherapy. And I think it's time to wake up and work on these areas. But aside from testosterone, which has also not been approved yet, and the safety and efficacy has not been well studied, we need to be careful when you're selecting our patient who use as testosterone at this point. But certainly we have started using in some individuals, and we have some great benefit out of it.
Professor Colombo, thanks for joining us. If I'm not mistaken, Sanjay, one question you mentioned about the obesity and weight loss and sarcopenia. I totally agree that although the EUS or even AASLD does not say is any BMI cutoff, but most centers use a BMI cutoff 30 arbitrarily, 35, 40 before transplanting, including the patients with MASLD and decompensated cirrhosis. So what do you think, how we want to address this issue with all the data we have? I mean, do we need more data, or do we need to form a kind of guideline? What do you think? How do you see we can change the conception? Because our surgeon said that, okay, BMI 45, bring it to 35, then only will transplant. And that's not realistic for most patients.
The reason of the region most surgeons shy away from this transplanting patient with high BMI is the first 30-day survival. The immediate survival following the transplantation high BMI, there's an increased risk of wound dehiscence, increased risk of cardiopulmonary complications. So the short-term mortality, if you are able to get this patient through that, they will do well. And the concern is not the long-term survival. Once they get through that first 30 days or 3 months, they will do well. And this concern, it continue to remain with the higher BMI. So I think you have to carefully select these patients, looking into other comorbidities. We have a patient who we had a BMI of 60, and we transplanted because the patient gained weight while on the transplant wait list, and they were committed to it and will do it. We did it, and all had some wound dehiscence, but that was it. But we got through, and finally we put the patient on GLP-1 and has lost weight more than 150 or 70 pounds in 6 months time period on GLP-1, and it's been doing well. So we survived through, got this patient through. But certainly that fear that will continue to remain. And we still have to be careful in selecting this patient with high BMI, particularly because of the high cardiopulmonary risk after the first 30 days and potential complications related to it. And if you are able to handle that, it should be okay.
So my question is, do you think, is there any way we can design another study to show that is not just the BMI? You can't base your transplantation criteria based on the BMI alone. We have to do something better than that.
Well, I think it's a good idea. Look, you are a transplant hepatologist. I'm sure you're many transplant hepatologists here. They all will share the same view and same thoughts. That certainly, I mean, indirectly, we're all doing it. When we're selecting out the high BMI patients, we are all doing it. But have we put a standardized protocol or standardized criteria? I think we probably like it, and we'll probably need some studies or maybe streaming. Maybe even the data that we already have, or something where we have a larger database and looking into comorbidities and how it impacts the long-term survival or short-term survival, actually.
Great. Anybody else has any question?
I just want to comment. This was wonderful. Thank you so much, Dr. Satapathy. I do think that some patients, if we use weight like BMI, sometimes they have a lot of ascites and all their weight is actually in their belly and their arms are so thin, their legs are so thin. So maybe we need something else for them.
Yes, a good point, actually.
Absolutely.
Sanjay actually mentioned that in his study, we had to correct the propensity matching the ascites part. But obviously, BMI or with the dry weight is probably a better way to do it. It's not perfect for these kind of patients with volume overload. Right, Sanjay, go ahead.
No, absolutely. That's a very good question. And we always think about it because particularly when you analyze these data, especially a larger database and looking at long-term outcome based on obesity, you have to factor into this ascites because many of these patients are decompensated with large ascites and their BMI is just inflated because of the ascites itself. And we have to factor into it. I think the only way, if you are realistically want to assess the true BMI effect, it has to be a prospective study, and you have to somehow account or measure the volume ascites in these individuals, and then extrapolate the BMI based on that. But it's not possible based on the large retrospective database where all this is not available and not collected. So we kind of factor into by adjusting ascites when you do like a multivariate analysis. And are looking at the outcomes of these patients with the ascites and the BMI, high BMI. So that's the only way to do that. With or without ascites, high BMI, then you factor them into the multivariate analysis. But I agree, certainly those may have an impacted as well.
Excellent. I think it's a great discussion. Thank you for everyone joining from different parts of the world. We'll continue to serve and improve ourselves, and thank you, Sanjay, for being the host all the time and allowing me the opportunity to host you this time. And with that, everyone, have a wonderful day or evening and great weekend. We'll meet again in 2 weeks.